Good morning, everyone, and welcome to our February 2023 community conversation. I'm Robin Shapiro. I'm the board chair of HealthAdvocateX, who is the presenter and sponsor of this particular community conversation. And before we get started, a few announcements. I would just like to do a land acknowledgement and acknowledge that we are on the traditional land of the first people of wherever we are, which is for me today in Maui, Hawaii, and for all of you all across the country. And we want to honor with gratitude the original people, past and present and future. I'd also like to establish this meeting as a safe place, and that means that every voice will be heard and respected. And we enter this space understanding that we all have different lived experience. And as such, we recognize that the potential for unintentional harm is there. And we as an organization are committed to healing should harm occur. I also wanted to just, before we get going, just recognize that it is Black History Month, and we have some specific programming that we would suggest that you all check out. Our last community conversation honoring MLK Day was really awesome and is available for free on our website. And also, we have an upcoming meeting March 27th, which is a screening of the movie Race to Be Human. And we'll be talking about racism and then have a post-film discussion with some really fantastic women who will be talking about racism and health and healthcare in the healthcare system. So we hope that you'll join us for all of that. So without further ado, we're very excited to welcome two doctors today, both connected to Swedish hospital system here in Seattle. Dale Reisner, Dr. Dale Reisner is the former medical director of OBGYN quality and safety and now has retired and is actually committed to doing a lot of consulting to help the medical system in a variety of ways. So she's applying her skills in that way. We're very grateful. And we are very honored also to welcome Dr. Veronica Zantap, who is a psychiatric hospitalist at Swedish Health Services. And so today we will be looking at the three objectives of differentiating between burnout and moral injury, how to reduce COVID infections, and we'll be obviously talking about where we are with COVID, even though we should be not talking about this anymore. We're in year 3 here. And then finally, strategies to improve patient-doctor relationships, especially in the face of, just tremendous mental health issues, both for patients, doctors, and medical providers. So I think you'll really enjoy this session today. And with that, I'd like to turn it over to Dr. Dale Reisner. Dale?
Yes, hi everyone. And I am really bored about talking about COVID all the time, but I will give you some updates. And I expanded my comments a little bit this morning. I hope you'll enjoy the tiny excursion from COVID specific in just a sec. So overall, global rates are still high. There's over 755 million cases. Obviously, we are not tracking cases in the same way we used to because so many people are testing at home and it doesn't always get reported. Some of the tracking that gets done for new cases per day, at least in the United States, is based on wastewater, which I just love that your wastewater doesn't go totally to waste when it comes to tracking all types of infectious diseases. And that's over 6.8 million deaths across the world. So that's a 1% mortality rate. And I think last time I talked to you about flu mortality rate, which is closer to 0.6%, I believe right now, if we look at people who are vaccinated. And in the United States, we're over 102 million cases. with 1.1 million deaths, and again, running 1%. So pretty comparable to what's reported in the world. I'm not going to talk this month about race ethnicity disparities, but please know we still have plenty of those, both in numbers of cases and in mortality. And it's a little bit different based on whether you're, Hispanic or Black or, and the Asian population seems to have done better than the Caucasian population in that regard. And then overall vaccinations, we still are running really low with a fourth jab, as they call it in the UK. So across the country, the most recent total for what that would be, if you're not talking about Johnson & Johnson, it would be either Pfizer or Moderna plus boosters, would be 4 vaccinations, and that's less than 16%, so 15.8% across the country.
Wow.
So, yeah, so the one thing I wanted to call out about this is pretty poignant, and that has to do with hospitalizations in the more vulnerable age groups. So greater than 50 years old, greater than or equal to, some of you on this call are in this group along with me. If you are greater than or equal to 4 months after your 3rd vaccination dose, you have a 55% hospitalization risk if you get COVID. If you are in that same group, so again, greater than or equal to 50 years old, but 1 week or more after a 4th dose, that booster that covers Omicron a little bit better, you have, that you don't, 55% protection against hospitalization, not hospitalization. In that same group with the 4th booster, you have an 80% effectiveness of avoiding hospitalization. So that 4th booster really does work against severe. That's really what it's meant to do.
And we don't know how long yet, I'm assuming.
We don't know the duration, and that is up for lots and lots of discussion. I think if you've had the 4th booster anytime, so your starting time would have been in the fall, you're probably fine in terms of protection against severe disease. Doesn't mean that you can't catch, you're going to necessarily avoid catching it if you're in a high exposure area. But more and more, the CDC and other infectious disease experts are coming together to recommend probably going to fall annual boosters along with the other recommended flu and anything else that you might traditionally get on an annual basis. So I think that is sorting itself out a little bit better. But
so does that mean we won't be
higher risk population?
Does that mean we won't be likely to see one until the fall?
You probably will not see a new booster shot till the fall. If you haven't had the 4th booster and you're in a high-risk population, I encourage getting it or considering getting it or talking to your healthcare provider about getting it if you have some concerns. So I think that's really the most I was going to talk about, the vaccine status and all of that. But I did want to talk about something that I was going to mention last month, and we had such a great conversation about disparities that I held it for today, and that's exercise. Exercise, and this is going to fit in with some of the things that Veronica's going to talk about. We're not going to focus totally on exercise, but everywhere you look, exercise has some benefit, even if it's not a lot. And there was a recent study published. Now, this has got lots of limitations out of South Africa. So we're not, not necessarily like the population that they looked at. But it's the first time that they've reported an association between regular physical activity and protective effect of the vaccination as well. So regular exercise actually boosts the effectiveness of the vaccination and minimizes the risk of severe disease as witnessed by hospitalization and or death.
And with that, maybe that would be good to share the source. I bet people would be interested in that. And can I ask you one
Yes,
other question, which is, was it statistically significant? Was it a
yes,
trend?
statistically significant. So I'll give you some
Wow.
numbers and then I'll tell you the source. But and more importantly, there's a meta-analysis that's been done looking at infectious diseases in general with physical activity that I think you'll appreciate. So let me just give you the numbers from this. So effectiveness against a COVID-19 related admission among vaccinated individuals with low activity was 60%. In moderate activity, it was 72%, and in high activity, it was almost 86%. So prevention of hospitalization. This, again, it's done in a very select population. These are people who are not the lowest income, doesn't call out race, and in a health study for a number of years. And the exercise they looked at, it's a retrospective study. So they looked at their exercise levels prior to the pandemic, because we all know that we had to decrease by some amount, right? So if you went to the gym, you were not necessarily going to the gym. But what appears to hold is that if you are a regular exerciser, people got out and took walks in the neighborhood or whatever when they could. If you're low intensity, then you tended to be more in the house, and some people physically can't get very much exercise, but just moving makes a difference. And for moderate activity, that is that's 60 to, let me get the exact definition they used in the study so you have it. So low activity was less than 60 minutes for a week. Okay, so that's less than 10 minutes a day. Moderate activity was between 60 and 149 minutes. And this is looking at overall per week. So there's different studies that have looked at longer periods of time for fewer days, but there's also studies that have looked at a little bit every day. And so they looked at total, and then the high was greater than 150. And how they define moderate intensity was having an average heart rate between 70 and 80% of maximum heart rate that would be expected for your age. So all of those are, I'm not going to talk about that so much, but those differences in the different categories. So with low activity vaccinated individuals had, if you compared them to moderate, there was a benefit of about 40% greater effectiveness of staying away from severe disease and hospitalization, and 2.8 times greater benefit if you were in the higher exercise category. Now, the majority of people are not in that high, but moderate is not that hard to achieve. So with that, and that came out of the British Sports Journal of Medicine, and was just published at the end of 2022. So the one thing that I think is a lot more generalizable, again, studies on this have been small and limited, but the 4 best studies were looked at in a systematic review process that was published in 2021, and so is not COVID specific at all. And this is pretty cool. So what they wanted to do was look at the association between habitual physical activity and the risk of any community-acquired infectious diseases. And I like this because that's the way we should be looking at this anyway, because something else is going to come along. Keep your fingers crossed that we don't end up with bird flu in humans, because that will be another disaster. So pay attention to that, you guys. With your contacts with any kind of poultry or the earth that they run around on. They're starting to see that in other animals that eat birds, like foxes and wolves and bears and other animals like that. So not in humans. But there's
And just
always something else that's going to come along because of how mobile we are. Yeah.
Before you get too far off that, I just want to backtrack and say, be careful. You said be careful of your risk and interaction with poultry. That does not or doesn't mean eating poultry.
No, it doesn't.
Okay.
But if you're around where
Chickens.
they're growing,
yeah, gotcha.
Chickens, yes, where they're growing them and stuff like that, then the earth that they're on can carry that. So this meta-analysis really looked at any type of community-acquired infectious disease, and they saw a 37% risk reduction with habitual exercise. And what they saw was in disease and in infectious disease deaths, related deaths. So the actually 31% risk in the infection rate and 37% risk reduction for death. And the thing that was super cool, prospective trials that were smaller and they brought them together, they had laboratory evidence of increased CD4 cell counts, which are one of our major responses for protection against infection. Immunoglobulin A, which is again an initial, it's not one of the things that we see when we've got an existing infection, but it's kind of what we see to protect us. And that was elevated. And also the antibody concentration after vaccination was higher when people had ongoing exercise. So that was regular, moderate to bigger. Yeah. And so I just wanted to leave you all with that, because as we are seeing, even people that have limited mobility, there are things they can do for some kind of exercise instead of just sitting or being in a bed or whatever. So the things that we can do with family, clients, and even slow walk around the block for someone who may have high obesity and have real increased risk for any type of community acquired infection, I think is really applicable, on top of where I think Veronica's going to take us a little bit with mental health, how we care for ourselves, how we look at caregivers, and both in the hospital and outside, and kind of where the state of that is. So I want to turn it over to Veronica unless there's any urgent questions.
Dale, can you share that meta-analysis
yes,
in the chat? Thank you.
Will do.
Thank you. Okay, so Veronica, welcome.
Wonderful. Thanks so much. Do you want me just to launch into what I'd like to share?
Yes, very much. We definitely want to hear everything you have to say.
Wonderful. Yes. So first of all, thank you everyone for letting me talk to you. This is the concept of moral injury that I want to talk about today, and kind of what's happening in healthcare is close to my heart. I'm a psychiatrist at Swedish, and so we consult on patients that are in the hospital for a variety of different health issues. So patients who are there for heart disease and for neurological conditions and strokes and cancer treatment. And one thing that's become very clear over the past couple of years is that we used to be called in to treat patients with, depression or anxiety. And now I would say 50% of the patients are dissatisfied with their care. And so they're being intractable, or they're being grumpy, or they're more anxious, or they're not getting better, or not agreeing to engage with treatment. And so that's why we're called in, which is very different from what we used to see. What's becoming really clear in healthcare is the following, is that healthcare providers are leaving medicine in droves. I have two physicians that I've seen for a long time, a primary care doctor and a neurologist, and I recently called in to make an appointment. Turns out they're no longer working. And so I wanted to find out where they had gotten a new job. It turns out they're both now in real estate, which is which is great if I was buying a house, but not if I need good healthcare.
Wow.
They're finding that healthcare providers are leaving medicine. Those that stay in medicine are expressing very high levels of dissatisfaction, job dissatisfaction. And what they're seeing is that providers no longer work as a team. So they're becoming a lot more kind of individualist, self-centered, not covering for each other, not taking extra shifts when needed, things like that. Very not engaged with the system. There's also a lot of what they're calling burnout right now. So burnout or compassion fatigue, and that's something that patients talk about all the time. We used to have these extraordinarily compassionate doctors, and now they just come into the room, they spend 2 minutes with me, they leave. Same thing for nurses. There are articles indicating that physicians are just dialing it in. So they're working at, in terms of their level of engagement with the patient, in terms of their level of engagement with the system, they're doing the minimum required just to maintain their jobs, but not more. And so the way that I think this has been framed for a long time. Oh, and actually, let me back up. The same is true for patients. So doctors are dissatisfied, patients are dissatisfied. Patients feel like they're not getting the care they need, they're not getting the attention they need. They don't know who to talk to in the hospital. There's a lack of communication. They don't always know what decisions are being made or have those decisions communicated with them effectively, or that they're allowed to kind of partake in their care plan, things like that. So, and also, what can we do about it?
Well, and I also think that when we were talking about this in prep, what's so important is, why is this happening? Because one might state that, well, this has kind of always been happening. So is this really different? And one of the things that I was really struck by in our conversation was a different level of productivity required from hospitals and hospital systems. And I think you're going to get into a little bit about how hospitals and medical systems typically measure performance, which I think is really important for our audience today to understand, like, why are people, like, one of the things that that was striking, I think Beth Droppert had sent this article around, was the New York Times editorial from physicians that they're not burnt out, they're demoralized. And so trying to pull the curtain back a little bit on why that might be happening, I think is something we're, really interested to hear about.
I asked Ashley to share that article because we posted it, but some people might not have gotten it yet. So
great.
And those are such good questions. I mean, I think this was happening before COVID, but COVID certainly was like the fire, or the gas, adding gas to the fire. Mm-hmm. And I think, I mean, it's hard. So physicians, I think there's a divide between administration and physicians in part, and then just, the financial realities of our current time and in healthcare. And, so hospitals are really struggling. And I think physicians became quite burned out with COVID, having a lot of, and I think it wasn't even so much that there were such high demands with caring for COVID, and it was such a horrifying, horrifying illness in the way that it affected so many people and so badly, but that there were things that people could do that they weren't doing, so I think for physicians, and I know that people feel there's a wide range of feelings about this, and so I'm just talking from my perspective, but as a physician, it was frustrating to see when people wouldn't wear masks or when they would be sick out in public, because that they're not just affecting themselves, but so many other people. And doctors are working so hard to keep COVID under control. And we're fighting a losing battle because people aren't wearing masks when they should, or, those kinds of things. And so I think that was hard, because at times we were working at different purposes in the patients that we were seeing. And that's not always the case, where we felt like patients weren't doing their part, and we were having to pick up the slack. And then in medicine, and generally, there's it's become much more, I guess physicians have always had a certain amount of autonomy, and we're losing that autonomy now because everything we do there's metrics. So everything is measured. I know exactly now how many patients I'm seeing, how quickly I'm finishing my notes, what my billing codes are, what the reimbursement is, and then having that compared to all my colleagues so that I can see that I'm falling short. And some of the standards are so high. So we have to, based on billing, we generate work RVUs. And so that's what everything is measured by now. If we don't have enough work RVUs, we can't hire more physicians to help us out. And the work RVUs are all based.
What's RVU? What is that? Can you define that?
What, Dale, you have to help me out here. I use the word so much now I forgot what the acronym stands for. That's like revenue-based unit.
Yes.
Yeah,
revenue value units or something. I think that's what the V is.
Yeah, and it's a little bit, I mean, a lot of it is arbitrary, but it depends on how you're billing. And so this is part of the problem, is that I spend probably 10% of my day trying to figure out all this billing stuff, like how to bill correctly and how to bill fairly, and how talking to insurance companies about covering certain billing or certain things that I want to bill, or certain procedures, things like that. And so I think that's part of the problem, is that physicians are just being asked to do too much and outside of their area of expertise, and it really comes down to money. So
and you don't get paid for that, right? I mean, that is basically your volunteer time is your 10% of your job, trying to figure out the money part. I mean,
well, you get paid for presenting that information, right? That's part of your job, but it's too much time in your job. It's not like it used to be simpler, where you would just sort of fill up this little thing and, for your visit amount of time or whatever. And it's become more and more labor intensive, which takes away the ability for the practitioner, whether it's a doctor or midwife or anyone, to really interact with the patient and to have job satisfaction. I think, would you agree?
Absolutely. Veronica? I mean, I think the focus, so I don't want to be overly critical of the healthcare system. I realize that this is being done for a reason. And a lot of it has to do with, healthcare systems struggling financially. And so trying to figure out how to allocate money and measure productivity to some degree. But in the last month, I know now I have to make 20 work RVUs per day, which means I have to see at least 5 new patients and 4 follow-ups, which, when you're seeing a patient and you have to see 4 more patients, that's, it takes away from the experience, the patient experience. And I do want to get back to how I have a workaround with this, because I think that's the most important thing.
Yeah.
One thing I do want to say is, I mean, with all these pressures that physicians face now, it used to be termed burnout. So a lot of doctors were burning out. And I think the problem with the term burnout is that it kind of implicates the physician. If you're burned out, it means that you're not meditating enough, or that you're not resilient enough, or you don't have enough energy, or somehow you're falling short of what the expectations are. And I think what they are, this new word, the moral injury, I think is more accurate, because what it really reflects is that there's a dissonance between what you feel is the right thing to do and what you were trained to do and what you're being asked to do by the system. And that kind of dissonance that prevents you from, as a provider, you go into medicine because you want to help people. And then if you're being kept from helping people the way that you want, that's a moral injury. And I think if that happens day in and day out for years, you start to get depressed, or anxious, or give up, or, I want to, focus on exercise and sleep and meditation, but that's not going to be enough to get you out of this dilemma. When I was talking to Robin and Dale, and also talking to colleagues, I think what we have to do, and I know the concern is that, you acclimate to a certain way of practicing, and then it gets worse, and then you acclimate, and then eventually you just end up completely burning out. I decided in this last month, and this was based on something that a mentor in medical school told me when I was a medical student. I think as a medical student, you suffer a lot of ego injury, or because you're at the bottom of the totem pole and all the residents and the attendings, and you're really kind of taking the flack for everything. And so every single day you feel like you're failing to some degree because you're not in a position where you're ready to be an attending it. And he would always say, when you're feeling that way, focus on the patient. That's the most important thing. This is all about the patient. It's not about your ego. It's not about the system. It's about the patient. And I found recently, when I go into a patient room and I stop thinking about the system and stop thinking about the billing and stop thinking about the RVUs, and I really just focus on the patient, that it helps me tremendously. And it makes me, it's almost, I had this patient I saw the other week, and he was causing difficulties for his team, and he was grumpy and intractable and wasn't going to do physical therapy. And, was he depressed or anxious, or could we give him medications to help this out? And I went in there and I sat down and I was like, hey, what's going on? And he told me about his life as a journalist and why it's hard to suddenly be in the hospital where you have no control. And, we had the most lovely conversation. And I stepped out of that room feeling like I was walking on cloud nine. It just gave me, I was able to connect to this person who's interesting and who's real. And I felt like my energy suddenly was really lifted. And I feel that whenever I do that, and I also don't think about the problem as, this patient's intractable, or, the staff isn't helpful, or, just really like, what is the patient's narrative? How are we going to figure this out as a whole team? That's incredibly helpful. What Dale had mentioned, and I think this is also helpful, sometimes patients can acknowledge that doctors are struggling in a difficult system. And if patients are able to give doctors a break, and other providers, and say, hey, I know this is not an easy time, I think even that acknowledgement really makes the relationship a lot better. And I think it compels you. It's you're sharing this common humanity, you're sharing a common problem. And if you can acknowledge that this is a common problem that you're not at odds about, but that you're like, you need to figure this out, it leads to really, really good interactions.
I think in the New York Times article, there was a statistic that in the last year, 100,000 physicians have left the practice and only 40,000 have entered it. And I think in terms of what the health advocate's role is in helping patients in the medical system, just to understand that sheer volume of personnel, brains, hands, just who is left are doing 10 people's jobs. Just that is pretty monumental in terms of providing compassion, even while trying to get what you want for your patient, because you still want to do that. I want to encourage people. Veronica's going to share a little bit more with us, but I want to encourage people to pose some questions in the chat, because we will get to a Q&A section here in a second. And I think the anecdote that you shared from your life, from real life, about what lifts you up, Veronica, is so valuable to understand and to think about as we're trying to navigate, how do you get through to people? I've had that experience as well with multiple doctors. They're not in practice anymore. They've just left, and it's hard, super hard to find people, much less competent people, to partner with. And so I think we're going to also get to some strategies for people in terms of improving the patient-doctor relationship. I don't know if we're ready for that yet, but
absolutely. And thank you. I love how you always how you kind of reframe things, and so I appreciate that. And it's a good question, and that's why I'd actually love to open up to other providers and to Dale. I know been doing a lot of Google searching on, what's going to make this better for people. And of course we can fight the system, and I think we have to, so that it's easier for providers and figure out a better way of healthcare delivery in the future. But for the time being, I think what I found, an article on compassionate care and how it actually, if you do approach a relationship with compassion, it leads to much lower pain in patients, much shorter hospitalizations, much less ancillary treatment, so less nausea, less medical complications. That's very motivating to me to know that there is a big role for compassionate care. It goes beyond just, connecting with the patient. It actually helps improve outcomes, and decreases the length of stay, all the things that hospital systems are concerned about. Then the other thing I found that was really interesting is if physicians and patients can share their stories, that decreases the cumulative stress. And so they have storyboards. Apparently there was a hospital system that had a board for physicians, and they were overwhelmed by the number of stories. But it helps to tell your story and to listen to other people's stories and to know that you're not alone, I think, for patients and physicians. So that's what I got. I feel uplifted talking to Robin and Dale. So that's another, just to know that people are thinking about these bigger system issues, that you're not alone, that you're not fighting something that all by yourself. And then I would say, if you can focus on your colleagues, my colleagues are amazing. And whenever, I feel so fortunate to work with them. And I think regardless of what's going on in the system, my colleagues are amazing, my patients are amazing, and that's not going to change.
Yeah, and I think for advocates to, hear from providers who are actually in these hospital systems is really helpful, because we actually can mitigate some of the feelings the patients have and some of the things the doctors are going through. So and I think our group supporting one another is important as well, because it's what we have to do right now.
Veronica,
thanks, Veronica.
Yeah, thank you for sticking with it. We need all the good people we can get. So given all the time crunch in the doctor-patient visit, is there a way that patients can share their story, demonstrate compassion, that advocates can be coaching patients to do that in a way that's not wasting time, but's meaningful and all that good stuff? Is there an ideal way to do that?
Yeah, that's such a good question. And I'd love to hear from advocates too, in terms of how that might be a possibility, to have patients share their stories, or even maybe to have a forum where doctors and patients together can share their stories, because I think that'd be extraordinarily important.
Yeah, and there's something in the chat about a relationship oriented or associated care, and whether doctors and other healthcare practitioners have access to any of that. I think there are traditional medical school training. It's not really there so much. And I'm not sure how the newer approaches to medical school training are addressing this. I know that some are more progressive than others. Mm-hmm. And residency programs are very focused on technical skills and less so on interactions. So there's opportunities there. But in practice, there are some examples. And I think I'll just give you the example of team birth, which is becoming now a national. In Washington State, our hospital association got a grant. And working with the Hospital Association and the Department of Health, we will have the ability to roll out team birth across the entire state, from small to large hospitals. It's a very simple process when someone is in the hospital giving birth. There's a big giant whiteboard in the room, and on one side is the patient's support people that are there or not there, but at least that they want involved in their care. And that might be for pregnancy, of course, the partner, the significant other, there might be a friend or a family member, et cetera. There might be a doula, which is, the OB version of health advocates across the country. And making sure that those folks are included in periodic rounding. And it also has the ability to reinforce and improve the nurse's sense of satisfaction with their job, because when the provider comes in the room, they address what's on the board, which is the patient's wishes and fears, and a really clear description of the plan for the moment or for the entire stay. And when there's a change, that goes on that board, and the patient can write on the board, as well as anyone else on his or her team. And then before you finish your huddle, which is this major kind of at key points in care, everyone in the room is asked if they have any other questions or anything else to add. And that really reinforces the whole team, brings the nurses who are there at the bedside way longer, their perspective and their ability to speak up for safety, and also as an advocate as well for the patient. Well, the patient, oh, you just mentioned this to me, and do you want to add that to your discussion before the doctor leaves the room, or before your midwife leaves the room? So that kind of approach for inpatient care, I think, as that becomes more generalized and spreads, and there are attempts to make that be national, that's going to have a huge impact, I think, on it's really recentering our care. As Veronica said, when you center on the patient, not only are your minor or less than minor irritations out of the picture, but why you went into medical care in the first place is reinforced, and that human connection and that joy of being able to help somebody is back in play. And I think that there are opportunities for that, even simple opportunities with an outpatient office visit. By if the provider comes in the room and you're there as an advocate and they don't pay any attention to you, to introduce yourself and say, hi, how are you? And I'm so-and-so, I'm here as so-and-so's advocate. And just make that, it's a little bit output from you as the advocate, but make that be embedded in every visit. Well, so-and-so's here. Obviously, if the patient is not speaking up for themselves, really every single interaction should be, what is it that we need to address? What's the most important thing we need to address for you, client, patient, today? Yeah. And given the limitations of what we have, let's hit that first, right? And if the provider doesn't do that naturally, how can we help them come into that way of looking at things? And everyone will walk out of that visit feeling better.
So I just wanted to make sure that Seema also gets in here, because she's had her hand raised for a little while. Seema, and then we'll come back to you, Veronica. Seema.
So thanks. Thank you for this presentation. This is sort of my reason for being, this whole topic. So for Veronica, I'm an OBGYN, practiced for a very long time, known Dale forever, and then became an advocate. And the reason is because we are being brutalized as healthcare providers. And I don't use that term lightly or as an exaggeration. We're being brutalized. And I used to say, which I still, obviously I don't really believe this, but, that we need violent revolution to overthrow the healthcare system. But so without the violence part, I think that we need to overthrow the healthcare system. And I think there is no way to, nudge it along to take care of us, because until that people providing healthcare are taken care of, it's going to be horrible, because you have to take care of yourself first, which I want to advocate for you doing, Veronica. You have to take care of yourself first. And that's a hard lesson to learn as a physician. And the, all the techniques are not gonna be enough if you are being brutalized by a system that thinks of you as a widget to provide this thing. And so anyway, I think we need like a whole restructure of the healthcare system. And the thing about
simple
being
to
an
do.
advocate that is
Oh,
so,
yeah, no problem.
yeah, easy. The thing that's wonderful about being an advocate is that you can help be the sort of the bridge between the different components, and I think can see which, what things are needed. And also, I think it's really, I want to say to advocates, I mean, I'm very protective of doctors and nurses in terms of you don't know what we have to go through to do this. So when people bash doctors, I put my, fists up, because it's an impossible task. And every time you have a problem, an interaction, whatever that doesn't go well with the doctor, you have to remember they're being beaten over the head every single day. And so people react different ways to that. Some people become really difficult to deal with, but it's the system doing it, not not that they're a necessarily ornery person. So I think focusing on the patient is good, and you have to, and that is what is rewarding about it. But you also have to remember that the system needs to just go.
Well, I don't know that you'll get a lot of argument, but I don't think that's going to happen. And because healthcare has become a bipartisan political tool, and it needs to be healthcare. It shouldn't, and when I say bipartisan, it is because it is partisan on two sides rather than becoming a cohesive bipartisan approach. So I think we're stuck in the moment, not saying that we shouldn't keep working towards getting a real system, because this isn't even a system. And I think the financial pressures are actually going to do it for us in a certain way, because healthcare is not for the places that have been for profit, and it's not a place where people are going to be making money. The in between time where we can do that on one side, but for the individual encounters, I think we have to treat them just as you say, have some sensitivity for who the caregivers are, but also not tolerate overt rudeness or injustices. I mean, I think we have to speak up for those things as advocates. And it's, in part why I felt like I had to start a little company and do a little bit of, quality improvement work on my own, where I can pick and choose the places I go, because I have a few talents and I hate to see them just go away. But it is really complicated. Like you're exactly right. Where you see people out of control, there's a reason for that. And Veronica's really highlighted that. You're just at your wit's end. And until you can take those moments like Veronica had with that one patient, the journalist who themselves was frustrated, and grab a little bit of that benefit out of our interactions in healthcare back. And that's why I really feel like as advocates and as an advocacy organization, we need to help spread tools around for people to make those one-on-one interactions go a little bit better while we're working on this other in the background. Because unfortunately, yeah.
And I do want to jump in here, because HealthAdvocateX does have a presentation called the ABCs of an Effective Doctor Visit that can be licensed to advocates to teach that. It's like a whole set of skills and tools for patients and other people in the community to help make that very, quick time the most effective that it can be. But I want to circle back to Veronica, because I think I cut you off a bit. So I want to recapture what you wanted to say.
Yeah, no, I'm actually glad. I loved what Seema had to say. I wish we could have a revolution, and hopefully, I mean, I think there's so much dissatisfaction now that something is going to have to give, beyond just doctors leaving the profession. I was just going to really quickly address what you were saying in terms of kind of the small changes that we can make, advocacy type changes, and you just brought it up, the ABC stuff, because when I was in residency, there's this one lecture which was how to make your 10-minute visit seem like 20 minutes or something like that. And I was like, this is a joke. You know, like, it's ridiculous. But there are skills you can use as a provider to make patients feel heard and understood. I mean, I walk into a room, I sit down, I do not stand, you know, you make eye contact. And I think studies have shown that doctors interrupt patients within 20 seconds of the visit. You know, so if you can hold out longer and let patients feel like they can say their piece, you know, and, you know, all those, so little tweaks that really make the interaction better.
Yeah.
Which
And
I think are very easy
that
for
is
people to learn.
exactly
I know that's
what
not going to
this,
fix the system.
yeah, no, it's not. But even the most simple things that some people won't think about, like if you're in the hospital, also having just a sheet about what's most important to that person and a picture of them being healthy that's posted by their bed, so that the people that are caring for that person see the patient as they normally are, not as the sick person in the bed, and they understand and can connect on a human level to them, you know, what's important, music or art or whatever else. So that ABC's talk is a lot about tips and tools for that, all with the same focus that you just mentioned, Veronica. And thank you, Seema, for bringing all of that up as well. I
just want to say, yeah. I don't want you people to think that we should not do anything until we can violently overthrow the healthcare system, because, but I feel, I mean, obviously I feel really strongly about this. I mean, I left my practice 15 years ago to start being an advocate, but I feel like it's healthcare, the right to healthcare is sort of like racism. We have to constantly push against it all the time, no matter what, and we have to live in this world. So it's sort of both, but just not to forget that we've got to constantly be working on this.
Yeah, good. Well said. Really, really well said. And I am kind of curious, Veronica, about if your system or other systems that you know of, in addition to the storyboard idea, which I think is fascinating. I'm going to go research that because I think that's a great idea. As a system recognizes these issues and have specific, you know, task force or whatever to focus on this compassionate care and moral distress issue. Like, is there a name for that? You know, we have patient experience. Everybody kind of knows what that is. Is there something or a focused effort that everybody knows the name of it, so they know kind of shorthand, okay, we got to really focus on this so we don't lose all of our doctor and medical providers?
Yeah, that's a good, and I'd also love to hear Dale's perspective on this kind of from a higher level. But I would say, I mean, there's the recognition now that this is an issue, and the fact that these articles are being published in the New York Times, that it is being called a moral injury. And, you know, more recognition has come to this because doctors are committing suicide at higher levels than ever before. Yep. So it's not just a matter of physicians complaining about it or getting burned out, like they're killing themselves, and that's not right. My sense is that we haven't progressed yet to a place where we're addressing the right things. And I don't think I think frequently it's kind of administration and clinicians are kind of working against one another, where, you know, where administrators are saying, you know, well, you know, we're, you know, even like sometimes we're giving you more money, or we're we're giving you opportunities to do more meditation and things like that. Like, why are you complaining so much? And physicians are saying that's not at the root of the problem. It's a systems issue, you know? And I think just some of that transparency is really helpful. Like, I love it when people.
You froze.
Yeah. Yeah.
Yeah,
Darn.
she froze. Till she comes back. I think
Focusing
what
on
she's
burnout or not making feel like they're at fault for this.
Yes.
Yeah.
Yes.
And you
you
froze
know,
there a little bit, Veronica. So I don't know if you can kind of repeat what you just said. We missed it.
Yeah, I was just saying, I mean, I think it's acknowledging that the underlying issue is a systems issue, and that the resolution is not going to come by physicians taking, going to meditating more, essentially.
Mm-hmm. Mm-hmm.
And I think as once administrators or once a hospital system can acknowledge that's going to be, even if it still is a problem, just hearing that from the top down, that it's not that you guys are not failing. We have to figure the system out better.
Well, and I think SEMA has always called this a social justice issue. And of course it is, it's a policy issue. And so it's not great that doctors are leaving, but one of the great things for our health advocacy field is that a lot of doctors are entering our field. And I think that's going to increase communication skills, not just between doctors and patients, but doctors and advocates, and hopefully we'll develop some semblance of a pathway to get policy changed, because it's a social justice issue.
Mm-hmm.
Yeah.
I love that, because I feel part of it too is that physicians are so, I mean, everyone is, not just physicians, but are so overworked. They don't have time for policy, right? Or time to get out there and advocate for change. So in working with advocates and working with other people who recognize the issue and know what to do, I love that.
That's great.
Yeah, I think that's a really good point, Veronica, because what I am seeing, especially with younger, newer physicians and Midwest, all practitioners, is this value of work-life balance in a healthier way than what I grew up with. And yet there's no allowance for stepping out. It's like black and white, right? That's work. I'm done with it. Here's my home. And what I'm worried about, and what I've advocated for within physician organizations, is that you also have an obligation to speak up for the things that you feel are not okay, whether it's access to contraception or other reproductive rights, whether it is undue laws that interact, with your ability to see a certain person, or that, certain people can't come into your care realm. It doesn't matter what it is. If you don't give yourself an opportunity to advocate in a separate venue for the things that you care the most about, then you lose out on that sense of satisfaction as well. I mean, I recently went to Olympia, our state capital, to advocate for women's reproductive rights and appropriate reimbursement for Medicaid care in the state of Washington, which is either the worst or one of the worst in the whole country. Like 47% of for offering the same amount of care to the people who need it the most. And I was like, it's a royal pain to go from Whidbey Island to Olympia and do that, to spend 15 minutes with each of 3 legislators. And I was down there, and I was driving down there, and I was like, why am I doing this? And yet when I came back, I was like, I'm in a county that's new to me, and I had a chance to introduce myself to those people, and they actually listened. So like, that is an amazing thing to do. You can do that in your own community, but you have to have in your head that fits into your non-work area, whether you call it volunteerism, I don't know what it is. It has to do with your moral compass
Yeah.
which is how you save that sense of humanity that Veronica's been talking about that gets lost along the way. So I'd like to see us talk about that a little bit more. It doesn't mean you have to go political, but where you can advocate for things in a way that actually doesn't take that much time, whether it's putting $5 into a campaign that you believe in, or, you know, whatever it happens to be.
Yeah.
That because if we do one thing at work, but don't have it spill out anywhere else, I mean, it may be that you're donating to a food bank. That's something above and beyond your immediate family and your work. So I just like us to think about that as an advocacy organization as well.
Yeah, that's great. We, the time has evaporated. The last hour has flown by, and I know that we could spend another very long period of time talking about many of these issues, but I just want to say thank you so much to Doctors Dale Reisner and Veronica Zantap. And this conversation has been super interesting. If you didn't get a chance to save the chat and all the good information there, I will be sending the chat summary unedited into by email to those who participated today. And if you want your CE, make sure that you fill out the survey that will be coming your way today. And we're happy to offer that CE for the live participation and then on demand. So tell your friends, because that helps support our organization. If you're interested in licensing the ABCs of an effective doctor visit, Ashley's posted that in the chat, and we're happy to talk with you about that. And we'll be here next month. Don't know the topic yet, but we look forward to seeing you then. And thanks so much to everybody. Aloha.
Thanks, Veronica. And
Thanks so
Dale.
much.
Yes, thanks.